So Morton's neuroma, as the name sounds, is a neuroma, as in a small lump in a nerve. That commonly happens in the foot, and it's in between your toes, typically between second and third toes, or between third and fourth toes, but it can occasionally be in the other web spaces as well. It can happen in one foot or in both the feet. Typically, that means there is a small knot or a lump inside a nerve that supplies the two sides of the toes. So this nerve you're talking about is a digital nerve or a small nerve in your foot, that there's one nerve in each of the web spaces. And generally, it's one of these nerves that is affected that supplies the two sides of the corresponding toes. The choice of footwear is one of the most important factors in causing or aggravating a Morton's neuroma. By this, we mean shoes with narrow toe box. So these are essentially the shoes which go quite narrow towards your toes, and therefore causing less space for this nerve and squashing the nerve between your toes. The second factor is shoes with big heels. For example, the fancy heel shoes often worn by women, that can be a triggering factor as well. And then the third factor often is patients or people who are on their toes a lot for the job, who are on their feet a lot, like working in shops, etc. And then the fourth, not very common, but fourth factor could be if somebody has pre-existing deformity or problems with the feet, like club feet, like caver's feet, or somebody with extremely flat feet. So these are the secondary factors that in theory can contribute towards developing or aggravating a Morton's neuroma. So it's diagnosed by a combination of history, examination, and then some tests to complement the clinical diagnosis. So in terms of history, typically, patients would often have pain in the forefoot. That could be a generalized pain, but often a localized pain between the toes, either the second, third, or the third, fourth commonly. And then this is typically aggravated by wearing certain types of shoes I mentioned before, or after being on your feet for a long time. This can be bad enough to affect your work. And then if the provisional diagnosis is a Morton's neuroma, the clinician would want to examine your feet to make sure there are no other problems like bunions, hammer toe deformities, etc., causing the pain. And then this condition, the Morton's neuroma, often has localized pain in the area of the neuroma, for example, in the second or third web space commonly. And then when the clinician presses in that area and squeezes your toes, you can often hear a click as well called Mulder's click. So that these couple of tests are very diagnostic for this condition. Then we often complement this with a series of tests. So we often do plain x-rays to rule out any significant bony problem or joint deformities. And then we perform either an ultrasound scan or an MRI scan, which is often diagnostic of a Morton's neuroma. It's a good question. Approximately about 15% cases of Morton's neuroma are bilateral. So about 1 in 8 or thereabouts, or 1 in 7 cases, our patients have symptoms in both the feet. So we generally ask those questions to the patient. If they come to us with one foot problem, we generally ask them about the other foot. And if they do have some symptoms, we ensure that the other foot is examined as well. And especially if they're having MRI scan, we like to then perform MRI of both the feet to ensure that an appropriate diagnosis has been made. So once a diagnosis has been established, the starting treatment generally is wait and watch if the symptoms are not bad enough. Change of footwear, for example, if you can start buying shoes with wider toe box, that often is useful. Reducing the height of the heels is often useful. And change of job, if at all possible. It may not be practical for a lot of people, but if there's a change of job where you can sit for a bit longer in between your shifts, etc., that can often help. For a lot of patients, these simple things may be enough to cure or certainly control the symptoms. If these things do not work, the next step is an injection using a steroid or a corticosteroid around the area of the neuroma. That can help to decrease the inflammation around the nerve and again can help reduce the pain. It doesn't cure the neuroma, but can certainly help with controlling your symptoms. And if none of these measures are good enough or they are not sustainable, then surgery is required. This is often a small surgery where a patient is put to sleep. You put a small cut or an incision on the top of the foot in the area of the neuroma, and we remove or cut out that knot or a neuroma from the nerve. That does cause some numbness in your toes, but functionally generally does not cause any problems. But most importantly, that intractable pain in your foot and going into your toes is almost always gone, and that helps to restore your quality of life again. If the neuroma goes untreated, unfortunately, the neuroma itself will never resolve itself. However, the symptoms may be resolved by activity modifications, as we discussed before. Slowly but surely over the years, it can continue to grow or get bigger, especially if the triggering factors have not been reduced or taken away. The only downside to that is that you may need a bigger resection of the nerve and may cause complete numbness of the toes once eventually the surgery is performed for this condition. Also, if the treatment starts early in the stage of your symptoms, it's quite likely that the simple measures, non-operative measures that I talked about, or even an injection is more likely to work than a surgery.